So I was asked to talk about a little bit about the basics of Alzheimer's disease. You'll hear later today from Sammy, who's going to discuss different types of Alzheimer's. I don't see him in the audience, which is good. Otherwise, he'd be telling me where I was wrong. But he's a really nice guy. But I'm going to talk about some of the basics, and he will talk about some of the other sort of disorders and different types of things related to Alzheimer's, so related disorders. We often use the term ADRD, Alzheimer's disease and related disorders, because of course as we go we're finding out this is a much more confusing than we thought. And we'll talk a little bit about that today. So first of all, my official disclosure from the University of Michigan. I have no money. If I did, it's all in my children's homes in Ann Arbor. And that's not that funny. And tonight I have to, Friday? Saturday night I have to park cars for the football game. And my daughter runs out of chocolate chip cookies she makes, and I don't even get that for payment. So before I start, I really like to thank everybody in the audience, because you all are really important. You all have led the interest and the concerns about Alzheimer's disease. You all have, frankly, contributed to our center or to the Alzheimer's Association. You all have also honestly paid your taxes, which means I get money from NIH to do my research. So you all are really important. The next slide actually would have been a thank you to the man who got me this outfit, because actually before this I gave a talk in Kalamazoo a couple months ago, and my wife and I were really proud of getting there 30 minutes early, and then I realized I had no suit or anything, because I hadn't packed that. I just packed for the beach in Muskegon. So there was a nice guy in Levitz who got me a suit and everything packed up and out the door. So you don't get that today. But today we should thank Jalen, who probably isn't even in here, because she's because she's desperately setting up our table. So Jalen called me at 6:15 and said, "Where are you?" So Jalen's the one to thank. So please visit our table out there, because it talks about all the different. Oh, that is Jalen back there. Jalen? Nope, that's not Jalen. That's somebody looks like Jalen sitting back there. Okay, but anyway. Please visit our table and take a look at some of the things there, because the table includes all of our different studies going on. It includes other research and other things we talk about, so it's a good reference. So now let me talk about why that thank you up there was so important. That thank you was so important because, frankly, you all, by your concerns and by the pushes and by the interests, basically have started a wave of things. This is Harry Johns, the leader of the Alzheimer's Association, which really has led this with who here has seen a commercial on TV about Alzheimer's? Anybody? Yeah. Who can remember ever having seen a commercial 5 years ago? Nobody. Right. So what happens is that you develop interest. Harry pushed that. Now we see several movies. Has anybody seen the Glenn Campbell movie? Yeah. That movie is really striking. If you've seen that movie, which also is available in pieces in YouTube, when you look on YouTube, go to the actual other movie that's on YouTube, or other section on YouTube, which was a CBS program about Glenn Campbell, and it's from his daughter's perspective. So the movie was from his wife's perspective. The other special is from his daughter's perspective, and they're both really fascinating in terms of how they respond. And people, have you all seen Still Alice? Anybody seen Still Alice? Which is also a very dramatic movie. So what happens is you get these movies, you get TV commercials we haven't seen, and what that does is it moves these guys, right? It moves politicians. Now, a lot of this work really started early on from Ronald Reagan, who really put the first dollars into aging research, but then not much happened. And then all of a sudden we had a number of people in Congress. If you notice, these are all from Michigan, which I think is pretty impressive. But a number of people of congressional leadership moved, and then Obama started the increase. President Trump has continued the increase, so there's been an increasing number of dollars put into Alzheimer's disease research, which is really critical, but only because people complained. And people got up and went to memory walks and things. And that's critical for the understanding. Now, what I'm going to talk to you today about, beside the sort of science, is what went on in Los Angeles. So I was asked to tell you what's sort of the latest in research. What are the things going on in research? So we'll talk about that today. And every year, used to be every other year, but it became so important and so clear, there was so much information coming out about Alzheimer's research, and now every year is the Alzheimer's Association International Conference. And so the Alzheimer's Association got together and decided we really need to find a way to get this information out, and if we're going to make progress in this disease, we have to get researchers together, right? You have to get people together to talk about it if you're going to solve it. And this is the only real conference for a single disease. You know, you get cardiologists together, you get neurologists together. I go to an annual neurology meeting. We do those things individually in terms of groups, but seldom is there a meeting about one disease. And so this group includes around 5,500 to 6,000 researchers in Alzheimer's disease who get together and just talk about Alzheimer's. And tremendous things have happened because of this meeting. We'll talk about that. So let's talk a little bit about the science of Alzheimer's. Let's think about what's the healthy brain. So within our brain, up here, believe it or not, there are billions of neurons. These are sort of the thinking part of the brain. And each one has an axon coming off of it that allows it to send through these little chemical synapses, these little chemical relation things, messages. So if I move my arm like this, first of all, the front part of my brain is going, why are you moving your arm like that? But the motor strip in my brain is keying itself off so that my arm moves. It's simple connections. But these little synapses that come off, there are trillions of these synapses in our brain. So you can imagine how complex this system really is. No matter how much we try, we've never really even been able to reproduce it with computers and things, human interface computers. So it's a very complicated system. It's also a system with a lot of interdependence, right? You put a roadblock in there and things get very confusing. So another thing I want to mention is what's Alzheimer's. So everybody talks about dementia. What's a dementia? What's the difference between Alzheimer's disease and dementia? So dementia is sort of that umbrella term, the overall term for any sort of decline in cognition, neurological decline over time. So Alzheimer's disease is the most common form, and that's 60 to 80% of the cases. So these are non-communicable. In other words, these aren't diseases that you catch from somebody. These are neurological diseases that occur. 60 to 80% of them are Alzheimer's. Vascular dementia is about 10%, but often vascular is intermixed with Alzheimer's. There are other types that are critically important: frontal temporal, Huntington's disease, Lewy body disease. All of these types are significant types of dementias. Significant types of dementia. But predominantly, Alzheimer's disease is the one right now we most often talk about. Sammy, this afternoon, Dr. Brahmata, will talk about these other types down here. But Alzheimer's disease is the one we tend to talk about the most because it's most prevalent. The history of it is pretty simple. The history of it is, little over 100 years ago, this guy named Dr. Alzheimer's met this patient in a psychiatric hospital called Auguste Deter. And he, at that time, was like way back 100 little over 100 years ago, it was mostly, hi, I'm a psychiatrist, neurologist, and neuropathologist. So I can see you when you start having a problem, and then later on I'll cut up your brain and see why. They used to be kind of general practice, do everything guys. But he met her in a psychiatric hospital, and he thought, she doesn't seem right. She doesn't seem like the rest of my patients. She has problems that really don't follow. So, you know, she has memory loss and disorientation, confusion and hallucinations, visual hallucinations and things that many of his other patients really didn't have. So she stood out to him. And when she died in 1906, when she was 55, he was able to study her brain, and he's the one who first found that she had amyloid plaques and tangles and atrophy in her brain compared to other people. This is the initial, these are the actual samples he used that are still around. And this is the picture from the samples. And you can actually see these things called amyloid plaque and these things called tangles where the brain cells are not right. We'll look at another picture of that. But he's the one that first found this. This disease has been in existence since the time of man. But he was the first person to actually say, wait a minute, just because you're getting older doesn't mean you start to have all these significant differences. He's the first person who posited that this was a specific disorder. And the idea behind this are these two pathological hallmarks. One, healthy brain cells with all those synapses and axon connectors become like this. You get plaques here in the brain, these tangles, and then the brain cells themselves begin to die. And then at the same time, you see that tau, which is really here, tau is really here to connect those axons together. What you find is tau begins to fall out of these axons, and then it also forms clumps, which actually are small enough to invade cells and cause damage in the cells themselves. So it's almost a simplistic process that occurs, but now we really understand in the last few years exactly what's going on with this disorder. Now, there's some argument as to whether the tau comes first or the plaque comes first. University of Michigan are tau guys. I think those Michigan State guys are more amyloid guys. But you know, I don't get into that argument. But in truth, these are the two foundational things that one sees when somebody has Alzheimer's. You have to have amyloid. And then tau somehow gets involved with that amyloid, and you begin to see this cell loss. And what you get is a healthy brain with clearly, in Alzheimer's, missing cells. And they're particularly missing in certain areas. Ventricles being larger means you've lost cell brain mass in the cell, so that the ventricles enlarge, those areas that control spinal fluid, begin to enlarge because cells have disappeared. And you especially lose cells in this inner side area, hippocampal area, that involves memory. That seems to be a key place where cells first get lost. So we kind of understand the fact that cells are dying. And now we kind of understand why. And one of the primary reasons why we understand why is in the last few years, we're actually able to image the changes in the brain. So we're actually able to say, look, we know that you get increased amyloid in the brain. What turns out what happens is amyloid really comes from something called precursor protein, preamyloid, which all the cells essentially have in their outer bodies. And these enzymes come along and they cut up this precursor, this pre-protein. And then it becomes proteins, and the cells can use those proteins. So alpha secretase, which is essentially a cook, an enzyme, cuts up this precursor, this pre-protein. The problem is if gamma comes along instead of alpha, the protein gets cut up wrong, and the cell can't absorb that big of a protein, and you get these plaques. They all clump together, and you get plaques. So this increased brain amyloid leads to amyloid deposition or plaques. So this is happening probably first or most dramatically, we know, and we can now image that in the brain. And this deposition leads to inflammation. You might notice people have often talked about brain inflammation as being a key to this. So you get this inflammation, and now cells are starting to dysfunction. And then we see tangles being formed. And again, we can actually mark where tau is seen based on those tangles. So we can mark amyloid and tau, and we can see that they have slightly different distributions, but they overlap in these key areas. And eventually, cells die, which we can see on an MRI. An MRI scan shows us what the brain looks like physically. These scans that have only been developed in the past few years tell us what's happening before the cell dies. How is the cell using energy effectively, or is it not? Or is there tau in the brain or amyloid in the brain? So we can now pretty well have a decision-making process that we know amyloid appears, and then tau starts to appear when cells start to fall apart, and then the cells die. Unfortunately, this is the time of diagnosis, right? Because we don't diagnose until we see symptoms. Because you have to have memory problems before you get diagnosed. The problem is this whole process takes anywhere from 20 to 30 years before you get down here. So that's the key to this is all going on. But we have markers for this now, but the problem is I can give you those two scanners at a cheap rate of about, I don't know, $5,000, $6,000. So it's not exactly something we can do all the time. Actually, $10,000 by the time you get rid of, the hospital costs and everything like that we have. But so this process we know happens. The problem is we can't do this for everybody. We can do it in the basis of research. The other thing that I get asked about all the time is, well, how come if you people are so smart, you haven't cured this disease like heart disease and cancer and things? Why is this the one disease that we haven't stopped, we haven't cured, we haven't prevented? These other diseases we all have approaches to often, like heart disease, right? But we don't have a result here. Part of the problem with this was that when August Dieter died, Dr. Alzheimer's presented his famous paper, and right afterwards, Kreplin, who thought he was more important than Alzheimer's, came out with his thing that said, oh yeah, you've identified pre-senile dementia. A normal part of aging just affects some people worse than others. The problem was August Dieter, and this is an interesting thing of science, was 54 years old. She had early onset dementia. Only a couple 100,000 people have early onset dementia in the world. But really, early onset dementia characteristics are the same as late life dementia, but because she was young, the assumption was this is only a disorder of a few people. So back in even the 1970s, of course I was in middle school then, but I happened to be working in research as a middle schooler. But anyway, when we were back in here, when we were back doing research in there, we honestly thought we were dealing with a disorder that only strikes a few people. But the problem was because we started studying brains, just as the person died, we imaged them. We didn't have amyloid and tau markers, but we had markers of change in the brain. We had something called fluorodeoxyglucose that showed us that in MRIs. We would image people right away, and we would start thinking, wait a minute, why does this 80-year-old woman who died, who had memory problems, why does she have the same problems that they have in Alzheimer's disease? Because in fact, then researchers began to realize that Alzheimer's disease is the same whether you get it early onset or whether you have the normal late onset. Essentially, the characteristics, the brain pathological changes are the same. So look, it took from her diagnosis in 1906 to 1984 to get actually diagnostic criteria, right? We have all sorts of diagnostic criteria. We have diagnostic criteria for heart disease, for cancer. We can say this, we can tell all the physicians together, we can say, okay, this is the diagnosis because the person has all these issues, right? Nobody had a diagnostic criteria until the 1980s because people just didn't understand. So it was really in this period in here where you really started to understand the idea of plaques and tangles, and plaques and tangles affected people young and old. We would see a brain of somebody, an autopsy of brain when they're 50 and when they're 80, and they started looking the same pathological hallmarks. So really from here on out, there tended to be a lot of changes, but even then there really wasn't the basic research done until the 1990s and things. In 2012, we finally got a new diagnostic criteria. And this diagnostic criteria talked about research diagnoses and clinical diagnoses. It also highlighted the fact that, for example, it's not just a switch between early periods and dementia. We also understand there's something in between called myocognitive impairment. And it wasn't until that last, most recent diagnostic criteria that anybody even set up a diagnostic criteria for myocognitive impairment. So we now know that you can diagnose a period of time in which individuals have mild problems that are clearly a change, but may not even affect their everyday life. But we know that over 5 years, half of these individuals will convert to Alzheimer's. Less than 10%, but that's still something, right, will improve. And 40% stay the same. And now we understand this process. I mean, years ago, back in the 70s and 80s, not that, again, I was in middle school, but I happened to be seeing patients, we had a woman I remember very clearly who came in with memory problems. Her family brought her in. She didn't have dementia, but she clearly had memory problems. And her family panicked, and oh my God, this is Alzheimer's disease. They got her a caretaker to take care of her, which worked great until the caretaker actually developed Alzheimer's. So this lady, whose memory problems never changed her whole life, who stayed within that, was one of the sort of unique numbers that stayed within that myocognitive impairment, she became the caretaker for her caretaker. So it's a unique issue, but it's not an on and off. We also understand, based on that characteristics, that some individuals start, or most individuals start as amnestic, meaning memory affect. And that's what we usually talk about, right? Memory problems. They're usually the first thing. But we also understood with this diagnostic criteria, now that we were spending time on it, that there's also something called non-amnestic MCI. That actually people can start with symptoms that aren't memory. They can start with executive dysfunction, more in the frontal lobes, actually. They could start with a visual spatial problem, more in the back of the brain. They could start with a language problem, more in Broca's area. So they could start with these different areas, but eventually the hippocampus and all these other things are involved, and the basis of all those starts are really plaques and tangles, but sometimes you get this mixture here. So Alzheimer's disease also is dramatically a significant increase in the US. It's the 6th leading cause of death right now. We have 5.8 million Americans living with Alzheimer's disease, and by 2050 we'll have 14 million. It's an incredible disease. The number of deaths of Alzheimer's disease are 4,428 in 2017. 169% increase since 2000. In individuals, we have 190 in 2019 individuals in Michigan, up to 220,000 in 2025. It's a significant disorder, and it's rapidly increasing. But we know it's not communicable. What's happening? You can't give it to somebody. Why is it increasing so rapidly? Because we're getting old. Right, exactly. But the point is, age is the most significant predictor of Alzheimer's. When you're 85, you have about a 45 to 50% chance of having Alzheimer's because age is the biggest predictor. But what are the other reasons? We're older, right? We're getting old. But why are we getting old? Because we're living longer, right? If you were in ancient Rome, your longevity was about 30. In Africa, where I do a lot of my research, in Kenya, for example, just about 10 or 15 years ago, the age was about 49 or so. Now, with antiretrovirals, the age is 66, close to 66. Again, it's different, right? We're living longer. There's Dr. Brahmata, who would tell us. I didn't see you were there. See, I was talking about you before, and you probably didn't. Oh, you were here. Okay. Anyway, so what is the other reason? So we're living longer. What's the thing? You got to know this one. There's more of us because, what's the name of this conference? Baby boomers? Right, because baby boomers. It's the aging population, because if you look at population graphs, right? If you look at population graphs back in 1960, and you looked at who's 85 or up or who's 65 and up, it was a little tiny spot. But by 2050, that little tiny spot will be big. It'll be rather than, have you ever heard of population trees? You know, we look at the age ranges. Well, by 2050, it'll almost be a rectangle because there'll be so many older individuals because of baby boomers. So that age difference, that's what's driving this increase. That's why there's such a significant concern, too, because 14 million people by 2050 will have an effect on a tremendous effect on our economy. The cost of that disease will be $1.3 trillion. I mean, you know, you're worried about breaking the bank for Social Security. This will break the bank for everything. That's why there's this increase. So let me talk to you about some of the latest findings from AAIC. That was a little short description of Alzheimer's disease, but it's also important for understanding some of the latest research findings. So some of the latest research findings' interest really in many ways was related to some negative information that came out. So a year before, Pfizer dropped its research in dementia medications. It had a drug that cost it $1.4 billion to develop, and the drug turned out to be not effective. And Pfizer just said, we can't do it anymore. We can't spend this money. A friend of mine works for Pfizer, and they sat in a big giant conference room in a really fancy resort and just looked at their data and looked at their data, and they couldn't find a way to fix it. And so Pfizer just finally said, we give up. Roche discontinued 2 drugs that were in phase 3. This is sort of the final trials before you start. In this drug was dropped right before the AAIC conference. Everybody thought that this drug that was hot news the year before, we all sat in the meeting and pretended we weren't taking pictures of the slides going by about this drug because it was so exciting 18 months in, but when the study was completed 2 years later, you didn't see the significant effects that were initially suggested. So, I mean, this is what happens. There was a study, that drug was studied at 1 year, and people were saying, oh, no effect. 18 months, looked really popular. 24, or looked really exciting. 24 months, when the study was completed, it wasn't. It didn't show an effect. So they dropped that drug quickly right before AAIC, and there weren't any presentations on it. At the same time, Biogen and Eisai, or actually about a few months before, Biogen and Eisai ended the late phase 3 studies of aducanumab. However, interestingly enough, they just announced the other day that, wait a minute, maybe we didn't do those analyses quite right. So now they're actually restarting this drug. But these are drugs that are plaque busters. They break up plaque. And they break up plaque in the brain to suggest that that may be what's going on. But the problem is, maybe the problem is not amyloid. Or maybe, remember we talked about that 30-year course? Maybe amyloid is laid in over those 20 years or 25 years or whatever it is before you start having symptoms, and maybe amyloid isn't the right place to look. Because maybe amyloid's already done its damage. So maybe taking away amyloid is not the idea. Maybe we need to think of other ways to look at this. So there are a lot of new suggestions now. You know, the thing about this conference was, unlike other times when everybody talked about, oh, here's the latest amyloid drug, let's really see it. At AAIC this year, there was sort of the statement of, golly, we haven't succeeded, but now we really need to look at all these other areas a lot closer that seem to be associated with Alzheimer's disease. Now we really need to look a lot closer. So there was a lot of looking at new types of drugs. You know, we only have drugs right now that affect the symptoms. Remember, because I told you, when that 20, 30-year path is finished and somebody has symptoms, then we start to give them what are called cholinergic type drugs that improve the choline, that improve the connections between those synapses. But we haven't probably been looking early enough. So now there was a lot of interest in new drugs. There was a beta amyloid. There was an early drug, but drugs that look at stopping beta secretase from coming along. So maybe that alpha secretase can be increased, the right things for cutting up those proteins. There's a lot of interest in looking at that. There was research on tau, on how to affect tau. Continued increase in inflammation for looking at, maybe we should be looking at brain inflammation. There was just a lot of studies going on and people waiting for the prevention trials. These were a set of trials that were started in individuals with early potential onset. In particular, individuals with early family onset. So the Alzheimer's Association has spent a long time finding families that had this early onset so that we could look specifically at what happens if you treat those individuals. Because it's the same associated disease process. So why would it be important, do you think, to treat individuals early in their 40s and 50s as compared to 70s, 80s? Do you think of some reasons why? Exactly. That's one of the things. So in other words, when you're younger, you're not carrying all these things like heart disease, diabetes, all the Parkinson's, all these other disorders that get kind of mixed in that make this disease much harder to identify. So the prevention trials are looking at individuals with early onset or individuals with a really sort of high risk for that disease. And they're beginning to look at these different drugs in those individuals thinking, now we're really going to see some relationships potentially. Because now we're going to say, let's affect amyloid early. And we also know that in these individuals with early onset, they get onset about 5 years plus or minus from their parent who did. They carry a 50% risk of Alzheimer's, essentially. So this is a very dramatic, significant disorder in those families. So If we can affect that, then we know probably the basis is right. But there are a lot of other drugs. And there was a new AMPAD platform which was developed for people to get together and be able to do these early diagnostic issues, looking at these early diseases and potential cures as fast and quickly as possible. So we don't have to ramp up a clinical trial. We'll be ready to go on things. Because of this concerns that we need to look at other things. There's an insulin drug, for example, that they reported, that 18-month results with inhaled insulin suggested a real improvement in 44 out of 49 people. And this was a study that was after the end of the study when they followed people who were taking insulin. Now, the truth about this study is, which shows you the kind of complexity that researchers face, because you need to kind of understand that complexity, this was true. It was quite noticeable, but that 44 out of 49 people did better. But actually, this study included 250 more people. Because what had started in the start of the study was they had an insulin nasal insulin device, and they said, you know what, that old one's not working. Let's switch to the new one. And actually, the old one worked. The new one didn't. So now there's a lot of thought about what the heck was going on. We need to understand this. But there was some suggestion that insulin may have been helping. Another set of trials are going on in gut measures. So bacterial infections, things like a severe type of gingival, a severe type of gum disease, that also appears that those bacterial issues also appear in the brain, can be found in the brain of people with Alzheimer's. So a lot of interest in what happens. I always have a lot of fights with my friends who study the gut, because I'm always making fun of them because they're always saying the gut rules the brain, and now they get to say they were right. So it's kind of, but there may be all sorts of issues looking at perhaps levels of inflammatory markers may be associated with what we see happening in the stomach and the gut. So there's a lot of interest in that. There are also other studies looking at, and especially in Lewy body disease, looking at inflammation. So what happened in this study, in this conference, was more than any other conference, there was a big increase that we've had so far, was a big increase in let's look at all the other associated issues involved. So last conference, there was the beginning of a discussion about what's going on with women in Alzheimer's. Why do we have more women with Alzheimer's? And now there was even more information. Honestly, some of it is confusing, because this is just the early information coming out. But it all becomes important to think about. So there were some sex-specific genes described and noticed that may affect resilience in women for Alzheimer's. That was really exciting. They also noticed a faster rate of memory decline among women who had never participated in the paid workforce. This was a follow-up to last year's initial suggestions that there was something going on. Memory between ages 60 and 70 declined 61% faster for women with children who had never worked. Now, this is really strange. What does that mean? Well, we don't know exactly what that means. Last year, the study found housework seemed to be associated with memory problems. So I can't tell you the reason why. These are just correlational studies, right? But we know that something about women is different. And there was one study that even suggested that tau distribution for women is different than men. So that there may be some basic brain differences that suggest why, but things are getting even more specific. So we know that cardiac disease was associated with non-amnestic MCI, but that finding was only in women. So there's something funky going on between men and women. We don't have the answer yet. But now at least there's a lot of attention to that, because probably from that work may come potential cures and markers. So it's really important. A lot of work this year. Last year was sort of talked about. This year really there was even more research on blood biomarkers, right? Because Why get that $15 set of scans, $15,000 set of scans, when we can use blood in the doctor's office? You go in for cholesterol and heart disease, right? Checks, right? So what if we could do a blood test that would tell us something about amyloid and tau in the brain? So there was a lot of interest in this. There was a new composite study in one of them that found correlations between brain markers and cognitive testing. This was a Japanese company. There was another whole set of studies on alpha-synuclein, which is really a key to how all these proteins may misfit across these dementias. There was suggestion of that. There was a lot more study on NFL, which initially had been touted as a marker for tau in Alzheimer's disease, but they actually found that the distributions were very different in other disorders, and in Alzheimer's disease, it wasn't so clear that NFL was really a marker for tau. So there's a lot of interest in these different approaches to look at this, because people are saying, wait a minute, we don't have a simple correlation for this disorder. A lot more research was done last year as carryover to the beginnings of the year before. This usually happens. You see some research one year suggesting some interest, and then more and more complex research comes out the next year on LGBTQ population. This is really important because what they found is that 60% practically are living alone, 65% have no partner, 72% have no children, and 60% had no identified caregiver. It's a significant issue in that community because there is a community that may not be getting appropriate treatment. And so one of the most really neat things that came was the PRIDE innovation, which was a dementia study as part of the IDEA study, which is a first-of-kind intervention designed specifically for the LGBTQ population. So specifically providing the important assistance necessary. Honestly, in the work I do in Africa, we are very targeted in our approaches to HIV illness, for example, based on the population we're talking to. Women working, young adolescents, and so forth. We're very targeting in the approaches we take. So this was really neat. This was saying, okay, we're going to target an approach and really look and see if we could improve these kind of features because of that. There was some interest in Alzheimer's disease and seizures, too. Among over 2.8 million persons in managed care, those with Alzheimer's disease had new onset 6.5 times more often. One of the researchers in our group is particularly interested in Alzheimer's disease and is beginning to look at these features. One of our early research education core faculty is really interested in this. There's another point here to take. Among 2.8 million persons in managed care, see that? Now, that is a massive number, right? So why can we do that? Because we can now do studies because we have healthcare systems across the country. Some people say, oh, God, that's a huge healthcare system. But because we have these large healthcare systems, we can now study millions of people at once. It's critically important. Now we're able to look at these wide-ranging sets of data. Other countries like Sweden have been doing this for years and years and years because they have sort of a managed healthcare across everybody so they can follow that. In another study using the same thing, these came out of the NAC, the National Alzheimer's Disease Coordinating Center, the big group that keeps all of our Alzheimer's centers together, around 24,000 people, AD patients twice as likely to have had a previous seizure. So a lot of interest in the potential importance of seizures or abnormalities in your EEG, your electroencephalogram, that may tell you something about either MCI moving to AD or normals even moving to MCI. We have a large study going on in downtown Detroit where we're looking at EEG markers that may tell us very early on what people in the community have so that we might be able to look at that as a marker for before somebody gets all these expensive tests.
I know here on the
A type of seizure would be something, so the question was, remember, notice everybody that I remembered to repeat the question. I never, where's somebody from the Alzheimer's Association? I'm always getting yelled at because I don't repeat the question. But the question was, could I give an example of a seizure? So a seizure is basically related to when the brain kind of goes abnormal, when you get normal markers in your EEG, your electroencephalogram. Because remember, I talked about it's just cells doing neurochemistry with each other. We can follow that on EEG. We can see these electrical changes in the brain. But when those electrical changes become erratic, that's a seizure.
How does that show to the outside?
We don't know. So the question is, how does that show in Alzheimer's? We don't know yet for sure. But if we know what your normal brain looks like on EEG, and we might be able to suggest how we could find what are the things that are predictive of Alzheimer's, that will be a big potential deal. So that's where that interest lies. Yes?
If this is out of line, just let me know. And I'll...
Happy to. But I have to be nice when I let you out of line because there's a camera on me. I have to be nice. Yep.
There are prisons that are loaded with individuals. We have them all over this country. And they have been in with vicious diseases. And when that disease, mind, creates a horrible activity outside of the conduct of anything that's, whether it's in Africa, I've spent time in Africa, I've been all over the world. And why none of the research is that you're talking about is reported, because everyone in the prison is there for a reason that is sometimes just irrational. And that behavior can be, it's never diagnosed or
Might
never
be
even
affected.
suggested that it's related. And it's momentary. And when these individuals do horrible things in the street, they're arrested. They have no memory of having done what they did.
Well, you know, it's...
Thank you.
Yeah, no, I mean, you're asking about prisons and the interaction with Alzheimer's disease or studying people in prison or things. I mean, look, we now understand these basic population questions. So what you're asking me about prisons is very similar, essentially, to looking at specific populations. So there's a lot of studies going on now, or a very large study going on, following priests and nuns. Because priests and nuns usually retire, now they don't have anything to do with prisons, but they usually retire to the same place, to the same type of place, the same type of retirement community. So we're able to follow those individuals through their lives from the tests they took, because most priests and nuns have to take some tests before they become a priest and nun. So now we can follow those whole populations. There's a lot more research being done on prisons and cognitive impairment. In Africa often, we have a real problem identifying Alzheimer's disease because Alzheimer's disease is not really discussed. So often patients who are acting oddly or wandering outside without clear reason are suggested to be psychiatric problems or other issues on the loose because they don't understand that yet. So there's a lot more understanding of this going on. It's just going to be more research necessary. We frankly haven't had the time to do research. That's the key with this, but now we have that. There's a lot more interest in Alzheimer's disease and sleep. We know that sleep seems to be an important predictor and issue here. Now, part of the research that came out last year was all about the importance of sleep. We actually have quite a group studying sleep at University of Michigan. But this was showing that the use of medications, but here's the confusing thing. The more research we do, right? Initially, it's confusing, and we have to understand the reasons why. So there's an increased risk of sleep medication problems in whites. So there's seems to be a suggestion that white individuals who use sleeping pills that don't work have problems, have more risk of Alzheimer's, but African Americans don't. It's really unclear. Men over 65 who use sleep meds were at increased risk of Alzheimer's disease, but women who used it successfully didn't have a higher risk. So it's not, you know, we've got to understand these differences in these issues. There's a new phase 2 trial, a trial just started in patients with Alzheimer's disease, that looked at if they can improve total sleep time, then you may find better behavioral concerns. Because some of these issues that patients have with sleep or other things as they begin to have mild to moderate Alzheimer's disease, we think that that may be an association with the brain problems. Maybe if you can affect sleep, you can keep the person up during the day and then sleep at night. But poor sleep quality also, again, in another round of studies, seemed to be associated with amyloid deposition. Poor sleep quality, use your CPAP, use your sleep issues, poor sleep quality does seem to be somehow affected with the risk of Alzheimer's disease. Pardon me? I mentioned CPAP. It is important to use your CPAP if you have sleep disturbance. So the question was about a CPAP. There were studies last year that suggested that people with increased sleep apnea had increased amyloid deposition. We don't know for sure what the association is yet, because that leaves bigger and better studies, but we seem to find some association with risk associated with sleep apnea. Again, it's something that we need to spend more time. But it does tell you, I put this in here just because it really is important to get sleep. We know that this factor is important. And these are sort of the highlight ways for making sure you get the sleep, like sticking to a sleep schedule, paying attention to what you eat, maybe lay off the spicy guacamole right before bed. You know, I've actually had that problem before. I can tell you that for a fact. You don't sleep as well. Reduce caffeine, obviously, late at night. Have a good bedroom environment. Bedtime rituals do tend to do the same thing. Turns out swimming and water exercises appear to make people do better with sleep. It's about the best way to put my 3.5-year-old grandson to sleep. Otherwise, you're in a hell of a problem. But avoiding sleep medications. Actually, some people feel like melatonin may be a better help than others. We don't know what's really going on there. Turning off the lights before bed, avoiding blue lights, using those computer light-associated things that change the light on your screen, all of those things may affect sleep. Sleep is important. We know that. Last year, there was a big increase in hearing. Last year and a little bit the year before and last year especially, there was a lot of interesting research that suggested that individuals with hearing, uncorrected hearing problems, had a higher risk for Alzheimer's disease, and even higher than some genetic markers for Alzheimer's. Nobody knew quite why, but it was really throwing everybody off that it was a higher predictor. So this year there was more research came out. And this research, you know, if you talk about hearing, the vision people come along and say, you know, you need to think about us too. But impairments in vision and hearing, having either visual or hearing impairment increased risk by 10%, having both by 112%. So there's something going on there. I can't tell you if it's because the person, if they have uncorrected problems, becomes sort of more to themselves and don't go out and reduce that social environment. We don't know the answer to that. Yes?
Aging, and so it seems to be a common denominator indicating that, oh, we could throw that in as well?
Yeah, so the question is it just associated primarily with age? Yes, there is a clear age association with vision and hearing, but among those older individuals, why is it that people with uncorrected vision and hearing seem to have a higher risk? If you account for that age.
Is there an answer to that?
There is no answer to that. We don't know. So the question is, what about more of that, and is it age associated? At the University of Michigan, there's a group studying specifically hippocampal changes with loud noises and things like that, and those kind of associations with hearing. We have 2 other studies going on now that are looking at participants with cochlear implants versus individuals with hearing loss to look at what that looks like over time and whether cochlear transplants that really improve hearing may lead to higher cognitive abilities in older individuals. We just don't know the answer yet. That's the problem with real research. And folks, the difficulty is if we were talking about cancer or heart, all of these things would have come out 40, 50 years ago. But now in the course of research, we're just beginning to learn about them now. That's why research in this area is so important. We're just now beginning to understand these changes because frankly, this research didn't start till 1980, 1990. Again, I was still in middle school back then, but that's when this first really started. Another set of studies looked at mild sensory problems, and they sort of took this score. Suppose we count touch, hearing, all these different aspects, sensory functions, and we put them all together in a little test, and we start doing that with individuals, what happens, and that study said a 7 times higher increase for those with the increased number of these mild problems seem to have a higher risk. So it was interesting. Yes? So that's a question about what about if those things are improved. With all of these issues, it's usually associated with uncorrected. So that's the key to this. So we haven't even gotten looking to comparing uncorrected versus corrected. That's the work, for instance, at Michigan that they're doing in otolaryngology, where they're comparing corrected and uncorrected and looking at aging effects over time to see if that affects it. Anybody get the vision down here? Anybody see the Avengers movie? No, okay. I just threw it in as a joke, but. So there's another set of studies that are interesting so this is Deb Levine. It's my old K awardee, but Deb is now, also she worked for me when I was in middle school, and now she's a tenured full professor who was really important, but Dr. Levine's work, she looked at 269 adults hospitalized after a heart attack. She found that cardiac catheterization was done 45% less for revascularization if they were MCI. So here's a whole nother question about this. These are highly affected treatments that are the first-line treatments for older individuals who have a heart attack. But in MCI, it was done much less. So the point is, last year, for example, there was a lot of research about why patients with mild cognitive impairment or Alzheimer's disease have too many hospital visits. We have to cut down the number of hospital visits, too many patients. But this is the reverse information. This is saying we need to look carefully at how we diagnose and how we make treatment decisions. And just because somebody has mild cognitive impairment should not keep them from good treatment. But there are a number of things suggested about this. Some of the physicians involved had the wrong idea about mild cognitive impairment. Remember, we talked about it. 5 years, 50% become AD. But that's only the general risk we understand. Doesn't mean that if you have mild cognitive impairment, you shouldn't get appropriate cardiovascular revascularization and things. This is common stuff. Wasn't done. This is a significant issue about diagnosing early. If we're diagnosing early, what does that really mean? There was a lot of interest in technology, sort of smart homes to help people remember how to do things. There's a smart mirror that tells you how to get dressed in the morning and don't forget to wash and don't forget to take your pills. There's a lot of new technology that's now being applied to Alzheimer's disease. And it was really interesting. I go to a technology meeting so the day before the actual Alzheimer's meeting starts, there's an entire day of technology discussions about all sorts of new approaches. Cameras people can wear that show them what they did during the day, and then in the evening or the next day they can review what they did, if they have memory problems or remembering. A lot of work on the Alzheimer's Association helpline that showed a significant effect if you make things available to people. So if you make an Alzheimer's health line available, if you make a telemedicine line available to individuals working in senior centers and senior care homes, if you have those things available, people will use it and it will work. The care line really significantly helped families make plans and other things. So there's a lot more example. My Brain Robot, Robbie, whatever it was, I went through a whole series of video series to start teaching children early on. I've now bumped into 2 studies on early exercise and cognitive change in very young children as a way of suggesting maybe we need to start really early with exercise and cognitive training and things we know might be important. Maybe we need to start with those things really early. There was a lot of interest in late, a different type of Alzheimer's disease that Dr. Brahmata will probably mention, that he will mention because this is one of his areas. But a lot of interest in this, that persons with late develop the disease 80 years of age and older. Rather than amyloid, it appears to relate to a different protein, TDP-43. So there was a lot of interest that maybe individuals later in life may not respond as well to the drugs we think that might help them. So a lot of much more attention to what was going on, and a lot of issues with prevention, right? We don't have that magic pill that everybody expected us to have right now. And even if we find that magic pill, the problem is every time you find that pill, it takes you about 12 to 18 years to get that pill into market. There's a pill for exercise, that's right. Well, the point is there's a lot more research on things like exercise. That's the whole key to this, is probably prevention may actually reduce some of that amyloid and some of that appearance of tau in the brain. So there was one suggestion that said that if you do 4 to 5 low-risk things, like exercise, not me on a treadmill, that's a high risk, but low-risk things, you had a 60% lower Alzheimer's disease risk. And participants with a high genetic risk for Alzheimer's, who had a number of those genes that seemed to be associated, who followed a favorable lifestyle, had a 32% risk. So even people with all those risks seem to have an option for how they can actually see some improvement. So a lot of this issue of maybe we should look at some of these things, but it's still confusing. Living in air pollution areas increased Alzheimer's disease risk, but older women with higher cognitive reserve showed 21% increased risk. Those with lower cognitive reserve showed 113% risk. Again, we're trying to understand, why are we just seeing these things? What do these things mean? A lot of interest in the pointer studies in the US. The pointer studies in the US really are designed, they have lifestyle programs, they have fixed programs of weekly health and things. Those are part of the worldwide finger studies. Notice that the first study came out in Finland, the original finger study. It's a 7-year study that said we're going to not look at one single thing. We're going to do the key things that, based on all of this research we've begun to amass with larger and larger numbers of people, we're going to do the things that we think might best lower risk. We're going to do physical exercise. We're going to do nutritional counseling to modify what we eat, because we have more information that things like high-fat diet that contribute to high cholesterol, diabetes, and other things seem to be an indicator, seem to be a risk. Cognitive and social stimulation. We know that one of the folks in our study, in our group, Dr. Dodge really studies specific interactions between older individuals in Japan that really seem to be associated with why in Yokohama there is this large cluster of individuals living to be over 100. Improve self-management of medical conditions. What if you control your heart disease, your diabetes? What if we really work hard on controlling those? And then let's do all these things. Let's do cognitive training. Let's do social stimulation. We'll do all these things in a community. The finger study that did that after 2 years with older individuals showed a dramatic, significant increase in cognition. So that got everybody excited, and soon we had a whole set of those studies. The Alzheimer's Association also really launched into this. For a long time, the Alzheimer's Association had said, no, we're really interested in finding that amyloid drug. Now that they see that that drug may not be as quick, we need to really look at ways to prevent this disease. They're now the central linchpin to all of these studies across the world, where all the data is being connected to the Alzheimer's Association. They're sort of acting as the data mother for all of this research going on across the world. But the point is a lot more interest in prevention. We know from other studies that these things like diabetes, people who stay socially isolated, they've done studies of nuns, we were talking about this before. We know that nuns who socially isolated themselves and talked about wanting to be a nun because of social isolation rather than I want to be a nun because I want to go out and work in the world, those nuns have a higher risk. Now that we can study large populations of individuals and we know what we're looking at, we have a much better understanding. We know prevention is important. I put up Jean-Louise Calmet. Has anybody ever heard of this lady? She was the oldest lady in the world in 1997. She was 122 years old. And she wrote extensively about getting older and what it was like, and she talked about this. She rode a bike, I think, till she was like 113 and fell off and broke her ankle, or 100 and something and broke her ankle. But she started every day with some olive oil. I think she even washed her face in olive oil or something. She ate right. She followed a strict Mediterranean diet, and she also drank 1 glass of really cheap wine a day. So she was kind of doing all those things. And by the way, there is some research that suggests that cheap wine that has more grape skin in it and things, so Cananoa grape wine is actually better for you, has more antioxidants and things. So I think she was right. Also, I'll mention this study because I kind of mentioned this when I talked about Dr. Levine's work looking at our MCI individuals probably taken care of less. There's a lot more interest in this. So if you remember, we have that cascade issue. So there's one group, very strong and important group of researchers who got together and said, look, we can now identify Alzheimer's disease early, right? We could say if you have amyloid, if you're a plus on amyloid, then you have preclinical Alzheimer's disease. We know you're going to get Alzheimer's disease. And then if you have amyloid and tau, you've moved into Alzheimer's disease. And if you have all three, neurodegeneration, if you have cells being lost that we can see the changes on MRI, and you have amyloid and tau, you have ongoing Alzheimer's. But the interesting thing here, right, was that early potential identification. So that sounded really interesting. There was a lot of back and forth about that, but there was also some really genuine concern about, well, let's think about this. If we identify people very early and call them preclinical or research Alzheimer's disease, or we only say it's a research diagnosis, it still may lead to changes in how we treat people that may or may not be a good idea. I mean, these are just issues, you know. That shift to treating non-symptomatic individuals is an issue. Asymptomatic disease may be very common and may affect many people who live and die before they get Alzheimer's. So I mean, these are just the kind of questions we're interacting with now that are important. What if you treated everybody with who had early Alzheimer's before even mild cognitive impairment, who just had amyloid? You know, drug expenditures on retail drugs would be just $200 billion a year, and right now every drug we're in is $333 billion. So these are just things to think about, but there are all sorts of things that suggest we need to really be working on prevention, not just the disease. There was even some work looking at the IDEAS study, which is critically important, showing us why amyloid in PET scans, the scans that I mentioned to you as being really expensive, but may be really critical to help doctors make that diagnosis, that doubled the use of medications for Alzheimer's disease, current medications in mild cognitive impairment patients. Now remember I talked about those are just drugs that help the symptoms, right? Doesn't help that cascade. That's all we have right now, but it doubled the use. So the question for some people was, these drugs have not even been improved for mild cognitive impairment. So what are we doing? So these are just some of the problems that happen. Researchers have to think of these ethical issues, and those are some of the things they're thinking of. Let me show you a little bit about the work. I have to end by 10, and I'm going to make it. So let me show you a little bit about the work that we're doing. So Ann Arbor, and actually Cleveland should be in there now, but they just became a center. But we're one of 32 centers if you count Cleveland. Don't count up all my dots, but I think there's 31 there. But if you count us, we're one of 32 centers across the country that were designated by National Institute of Health as centers of excellence for Alzheimer's research. We have clinical trials going on. We have studies looking at memory training, cognitive ways to improve cognitive performance. We have lifestyle intervention studies. We have biomarker studies. We have a lot of studies about caregivers. These are the things that we have outside that, again, I ask you to look at the break. I know you didn't get a chance before much, but look at the break. One of our primary studies is called the Michigan Memory and Aging Project, which just follows individuals over time and looks at their cognitive changes and skills. We're looking at healthy controls. We're looking at individuals with mild cognitive impairment, just to follow them over time and once a year give them a physical and medical and neurological diagnosis and some cognitive testing and see what happens to them over time. These are also individuals who really want to do research. We have a few other studies. We have Armada going on, which is validating a tablet-based cognitive test that's suggested to have early indicators that it may be an early indicator of cognitive decline. We're looking at this test out in the community to see how effective it would be to actually be doing this in a community group. We have a number of studies looking at couples and well-being that Sharia is doing, looking at couples and well-being. We have the Reveal scan going on that's looking at what's the best way to communicate whether you have amyloid in the brain. You know, there's 23andMe, right? Is that right, 23andMe? Got that right? There's 23andMe. If you do 23andMe, they give you all your genetics that we have. They give you your ApoE. They give you other predictors of disease. Well, what does it mean? What do you do with that information? You know, you carry ApoE, so you have a risk for Alzheimer's that may express itself when you're 160 years old. I mean, what does that really mean? But what do people have to understand by doing that? So the Reveal scan is looking at that. There's a lot of interest that's been developing over the past couple years in vision scanning. The eye is the window of the brain. There's a lot more interest in using retinal scans and other things to look at this. We also have iConnect. That's the study, one of the studies I mentioned Dr. Dodge is doing, looking at connections between older individuals as we get older and connecting them through the computer. The Stimulation to Undermine Dementia is a study that's looking at using very simple, mild, sort of battery-based induction of changes in the brain. What if we can use what's called TDCS to stimulate the brain? It's got basically a 9-volt battery in there. We're looking at another one with a drug to look at early effects in mild, moderate, and Alzheimer's disease, and another drug specifically looking at Lewy body disease. We have a number of these different trials going on for all different things. We also do a lot of other things. Edna leads our minority outreach team. We've done a lot of work in these areas. We have a brain bank, so individuals who have been in any part of our studies can also donate their brains to us so that we can actually look at these brain changes very carefully. It's something Dr. Ramada does, Dr. Paulson does in our group quite a bit, looking at these things. Alzheimer's, dementias and autopsies are critically important for looking at differences across cultures and across time. We have a very strong Lewy body initiative with a lot of statewide awareness, a number of support groups. We just got awarded a recognition for the work we do in Lewy body disease. It's really important. Again, flyers available outside. Caregiver wellness initiatives. I usually try and sort of stop close with this slide because every time I look at Laura, I get relaxed because she runs all of our relaxation and meditation studies. So now it's worked very effectively. The psychology of it and the training of it. Now, if I just see Laura's picture, I get relaxed. So I don't even have to go to all these caregiver meditation and mindfulness things we do. I just look at Laura and I'm fine. But we do a lot of work in that area. So we really need you guys to volunteer for research, to spread the word about dementia. Every year, we've missed it this year, but every year there's an Alzheimer's walk you can volunteer to be part of. You can be part of our research studies going on. You can look at our table out there and see everything going on. And I'll just give you an example of why it's important to do research. I'll end with this. These are the number of papers published in AIDS and HIV research, 0 to 10,000. You can see that the numbers over time have really increased and sort of asymptoted off. If I look at the number of studies published in Alzheimer's disease, you can see that's gone up dramatically, right? We're doing our job. But this is the number with cancer. It dwarfs these. We need to do more research. We need to look at these things. We also need to look at some of the approaches that cancer research does, for example. Not this year, but last year we got yelled at by a cancer researcher who kept saying, you all aren't studying this appropriately. You need to look at this disease the way we do in cancer, looking at the genetics of things. Last year, there was one of the first studies reported that said they looked at the genetic and gender makeup of this population to predict who might have the best effect to a disease. So all these things are important. You can contact us. There's us, or some of us, most of us are right there. There's our website, or you can contact alz.org. You're connected to us, and we're connected to them. And I think that's it, folks. Thank you. Yep.